Yes, we can.
Okay, wonderful. Thanks, Chandra. And good afternoon, everybody. Thanks for joining our media information session on COVID-19. As Chandra mentioned, my name is Natalie Balking. I'm the Medical Officer of Health with Haliburton Kawartha Pine Ridge District Health Unit. And we have been providing these weekly information sessions just to provide updates on COVID-19 certainly to our local media, as well as to residents that live across HKPR District Health Unit jurisdiction. So my update's going to continue, or is going to follow the same format as previous sessions. So I'll start with an update just around the numbers and talking a bit about COVID-19 activity in the region. Have an update also on vaccination and then an update on other public health measures. So to begin with our EPI update, so to date, we've had a total of 4,858 lab confirmed cases of COVID-19. We currently on our website have posted on our dashboard, we have 1,124 lab confirmed active cases of COVID-19. At last week's session, we talked a little bit about how changes in the guidance for testing is going to impact how we look at our day-to-day numbers on our dashboard. Knowing that not everyone is able to access a PCR test if they have symptoms for COVID-19, we know that the number of active cases on our dashboard is not reflective of the actual number of cases of COVID-19 in the community. So we expect and assume that there are many individuals that either have symptoms of COVID-19 but are not tested, and so we presume them to have COVID-19, or they have tested positive on a rapid antigen test. And any of these individuals will not be seen in the numbers on our dashboard right now. So while I can share a number on our dashboard of the lab confirmed number of cases, it doesn't include the whole, I think, burden of COVID-19 the community is currently experiencing. That being said, I think it's still a proxy measure or indicative of COVID-19 activity in the community. Yes, it's a smaller portion of the population that is accessing these tests, but if those numbers are still high, it's still signifying that there's a lot of COVID-19 activity in the community. Similar, and I think, information to consider when we're interpreting what our rate is per 100,000 population. So we saw our rate peak at around 5 or greater than 500 cases per 100,000. And in the last couple of days, we saw it come down just a little bit. Now, this is a reflection of the change in access to PCR testing and is not a reflection that we're starting to see a decrease in COVID-19 activity just yet. I think there are certainly other measures that we can start to look at that will let us know when we start to see decreased activity overall. Our test positivity is one of those measures, and our test positivity, so this is the proportion of tests that are positive from all of those people going for PCR tests, and it has remained high, certainly higher than at any point in time during the pandemic. So as of January 4th, we were at around 22%. This test positivity, certainly high for our region, is still actually lower than the provincial test positivity and lower than some other health unit jurisdictions. So while we're seeing, yes, quite a lot of activity of COVID-19 infection, we are, I think, still faring somewhat better than other areas of the province. Another indication of wider spread COVID-19 activity, other than just case numbers, is the number of outbreaks that we have ongoing. And this number continues to rise every day. So we're currently sitting at 30 outbreaks that have been declared. I believe 15 of these are related to long-term care homes and retirement homes. I think of note is that the definition of an outbreak has remained unchanged throughout the pandemic. So the definition of an outbreak is still if there is more than one case, so at least 2 cases with evidence of transmission at the facility. So this could involve transmission from staff to staff or staff to resident, or resident to resident, or resident to staff, any combination of that. But if there is evidence of transmission at the facility, then that's when an outbreak is declared. And so again, right now we're looking at around 30 outbreaks, at least as of this morning. And again, every day it increases by a handful. We're only reporting outbreaks in higher risk settings, which is long-term care homes, retirement homes, other group homes, correctional settings, and we are not reporting outbreaks on other community settings such as hockey teams, etc. In terms of a few details about characteristics that we're seeing from cases, and our data on this has been limited because we're not collecting the same information. All of the cases that we're seeing right now, unless they're associated with an outbreak, are being forwarded to the provincial workforce to follow up. So a provincial team that follows up. But we do know that there continues to be almost 30% of cases that are among young adults, so between the ages of 20 and 39. We are seeing higher rates of severe illness across aged care jurisdiction compared to, I would say, a month or certainly 2 months ago. In the last 14 days, we've had 14 residents admitted to hospital with COVID-19. 8 of those individuals age 70 or above. So certainly a higher risk of needing hospital admission among older age groups. We have, however, had 2 hospital admissions among the age group of 10 to 19. So we know that people can develop more severe COVID illness if they're younger as well, just a lower risk associated with that. In the last 14 days, we've had 3 individuals admitted to ICU with COVID-19 infection. Again, 2 over the age of 70 and then 1 in the age group of 60 to 69. Unfortunately, we have had 5 deaths associated with COVID-19 over the last 14 days, and all of those individuals have been age 70 and over. So again, seeing kind of the risk of severe illness, ICU admissions and death associated with COVID-19 among individuals that are older. And this is consistent with other waves of the pandemic. I know that people often inquire about vaccination status of individuals that have been hospitalized or have been admitted to ICU. Among those admitted to hospital, I believe it's and I don't have the exact number. I'm going to have to go back and double check because I didn't include it in my notes today for some reason. We have not had any hospital admissions among individuals with 3 doses or a booster dose of vaccine. We have had several individuals that have been received 2 doses of vaccine. And I think this isn't a surprise. We know that that 2 doses of COVID-19 vaccine is not as effective against the Omicron variant as it was against the Delta variant. A booster dose is demonstrating a good boost in immunity and significant improvement in effectiveness at preventing both symptomatic illness as well as severe illness from COVID-19 following that booster dose. And I think there's very good provincial data that continues to demonstrate the risk of either hospital admission or ICU admissions among individuals that are unvaccinated relative to individuals that have received 2 doses of vaccine. And then further to that, as more data becomes available, we'll see the impact of booster doses on protection for that. Otherwise, I think I'll move from here on to some updates around testing, and this is really just a reminder. I spoke to it at our last session. A reminder that eligibility for PCR testing, as I mentioned, has changed. There's a limited number of groups that can access PCR testing, and this is really about prioritizing testing for either those individuals that are at risk of severe illness from COVID-19 or are working with populations that are very vulnerable to severe illness of COVID-19. So those groups that are eligible for PCR testing include healthcare workers that are symptomatic and could potentially have COVID-19, as well as those people that are symptomatic and have medical conditions that result in their immune systems being compromised. And then people that don't have symptoms but are associated with an outbreak at a long-term care home or at another highest risk setting. Otherwise, the guidance really is if you have symptoms to stay at home, to isolate. If you have access to a rapid antigen test, please go ahead, use the rapid antigen test. If it is positive, you do not need to go for a PCR test to confirm that it's COVID-19. Assume that the test is correct and that you have COVID-19. You'll recall we went through some of the updated guidance on isolation last week, and it does depend on both vaccination status, as well as if you have a medical condition that results in your immune system being compromised, or where you work, if you work in a high-risk setting with individuals that might be vulnerable for COVID-19 illness. And so depending on those factors, you'll be asked either to isolate for 5 days or for 10 days. I'm going to move to some updates around vaccination. I think we continue to make good progress in access to boosters. Among the population that is age 70 and over, we've hit just above 70%, so 70.4% of people age 70 and over have received their booster dose of COVID-19 vaccine, which is great. Certainly knowing that this age group is at highest risk really of severe illness from COVID-19, we continue to encourage anyone that has not had their booster dose to please go out and get your booster dose. There's plenty. I'll speak to in a minute to kind of access to vaccine and give some updates related to that. Among our population that is age 18 and over, we're at 43% that have received their booster dose. So again, steadily making progress. As we look at other other age groups and vaccination coverage, we've continued to make very incremental increases in the coverage among the age group 5 to 11. So young kids or school-age children really, we saw at first very good uptake. I think really keen parents, the ones that were quite anxious to get their kids vaccinated, and I wouldn't say that it's stalled, but the rate of increase has certainly leveled off among uptake among 5 to 11-year-olds. We know that there are some 5 to 11-year-olds that in the next couple of weeks will become due for their second dose. The current recommendation is 8 weeks between their first and their second dose. But we still are encouraging parents to consider, to think about, to access all of the resources that are available that talk about the risks and benefits of COVID-19 vaccine for this age group to be able to get their kids vaccinated against COVID-19. A couple of reminders just about eligibility for vaccination. For 5-year-olds, the eligibility is by birth date. So the child has to have turned 5 already to be eligible for their COVID-19 vaccine. So if somebody's 4 right now, turning 5 in March, they need to wait until March. And for booster doses, an individual has to be 18 to receive that booster dose at this point in time, unless they work in a highest risk setting, such as a long-term care home or hospital. And this is also by birth date. So if somebody is 17 right now, turns 18 next month, then next month they would be able to access their booster dose. We do have an ongoing shortage of adult Pfizer doses of vaccine, and as such, we continue to offer Moderna vaccine for individuals that are aged 30 and over at health unit-led immunization clinics. There's sufficient supply certainly for the pediatric dose of Pfizer. And then for individuals aged 12 to 29, the adult Pfizer we do have is being reserved for this age cohort because it is the preferred, or there's a preferential recommendation for Pfizer vaccination among that age group. We are seeing some people decline Moderna vaccine, either when they come to clinic and realize that Pfizer vaccine is not available and they are not under the age of 30, or have canceled their appointment. And I think I have to admit, I don't fully understand all of the hesitations around Moderna vaccine, especially when we read some of the latest data about Moderna vaccine having very good data demonstrating a boost in immunity, certainly equivalent to Pfizer booster dose, if not slightly better than Pfizer booster dose, and with a longer duration, potentially of protection. When we think about when I go through in my head other reasons that people might be hesitant to get Moderna over Pfizer, sometimes people talk about side effects. We know that Moderna tends to have more localized side effects, so sometimes a higher or more often a red sore arm with swelling, whereas Pfizer sometimes has more broader side effects like muscle aches and fever, but really not a significant difference in the rate of side effects between the two. Again, both equally as effective. And then there was certainly previously concerns about travel and mixing and matching vaccines, and with this booster dose, I think those concerns really aren't relevant, and most countries have adopted and recognized the emerging evidence around certainly mixed doses of mRNA vaccines, as well as a mixed series of viral vector vaccines and mRNA vaccines. So I do encourage people to get the booster dose of the vaccine that's available to them. And right now, Moderna is what's available for people age 30 and over, and unless there is an allergy or a specific reason they're not able to get Pfizer. We have heard from the province that we will hopefully receive more Pfizer before the end of this month, but again, I wouldn't wait, knowing the benefit right now of receiving your booster dose in helping to protect against not just symptomatic illness, but also hospital admissions and ICU admissions. In terms of access, again, multi-pronged approach, as we've seen really for the last year. So there are health unit-led immunization clinics. We continue to have appointments that are open. Even day of, we are continuing to have appointments that are open. From now until February the 6th, we have 8,463 appointments that are open for adults to receive their first, second, third, or booster dose of vaccine. So for those people that would like to book an appointment, you go through the provincial booking system to access that. We also know that there are primary care teams that are offering vaccination clinics, and pharmacies continue to offer vaccine. And again, I think vaccination is one of the most, if not the most important measure we have right now to try and blunt the impact of Omicron on our healthcare system. So working to prevent people being admitted to hospital with severe illness and ICU, so that we can continue to offer healthcare services for all of our many needs across the province. Finally, I'll couple of quick updates just about other public health measures. So I know top of many people's minds has been the return to in-person learning at schools as of next Monday, or January the 17th. And I know that the province was making an announcement today, and I think they were still speaking when we started this media inquiry. I was listening in. My understanding is that the intent is to continue with a return to in-person learning on Monday. We are in collaboration with Peterborough Public Health and the Durham Region Health Department hosting an information session for parents and guardians on return to in-person learning tomorrow. So it's a virtual event at 6:30 p.m. In which we'll talk through the prevention measures that are in place for schools to help prevent COVID transmission in schools, as well as looking at the changes in guidance related to case contact management in school settings and other childcare settings. So I think certainly if people have questions, I'd encourage you to log on to that event. I believe that their questions are accepted ahead of time, and we'll try and make sure that we cover all of them throughout the session. But I'm sure there's going to be many more questions over the next couple of days as we move towards a return to in-person learning on Monday. Otherwise, I know that I've spoken for about 25 minutes or so, and I'm sure there's lots of questions. So I think what I'd like to do is to pause here and open up for questions, and we'll go from there.
Okay, great. Thanks, Dr. Bocking. As always, lots of good information, lots of things changing from week to week. So lots of good things. I see Dan's got his hand up. So Dan, do you want to go ahead and ask your questions?
Yes, thanks, Chandra and Dr. Bocking, as always. Just first off, on the return to in-person learning, I guess back in December, you mentioned a concern about an increase in school-aged children cases, I guess. And with the return to in-person learning, I guess, are you concerned that this could maybe lead to more community spread within this age group?
So I think a couple of key principles here. So one is that cases among school-aged children really is a reflection of the amount of COVID-19 activity in the community. So we did see an increase in COVID-19 numbers among school-aged children. The vast majority really, though, had acquired or gotten their COVID-19 infection outside of school, so through some other exposure. We have not seen, certainly in our jurisdiction, widespread transmission in schools. Even in the outbreaks that we have seen in schools, they have been very small numbers. We know that there's really a layer of protections that exist at schools to help prevent transmission. But as long as we see widespread activity in the community, I think that we certainly there will be children of school age that will also develop COVID-19. I think the key important measure is that in the existing or updated guidance right now is that if the child is sick or has symptoms consistent with COVID-19, or a household member does, that they're staying home, they're not attending school. And I think that this is going to continue to be a bit of a paradigm shift to what it was pre-pandemic. But I think that we're all working together to be to keeping our communities healthy.
Great, yeah. And on the vaccination of 5 to 11-year-olds, Jess, what can you say to parents to maybe ease their concerns a bit more about having their children vaccinated?
Mm-hmm. Well, I mean, as a parent, I understand that parents make decisions because they want to keep their children safe and healthy. And that really we're making decisions that we believe are the best for our children. And COVID-19 vaccines are still relatively new. For being relatively new, they have, however, been used by millions of children in this age group now, both in Canada as well as the United States, for which we have good data on. The safety data is very reassuring. Very similar kind of local side effects or occasionally a fever, broader body aches. There's been no indication of more serious adverse effects at a higher level than you would see with any other vaccines. And so the safety data really is there to support its use. And I think the protection level is there as well, or evidence around protection. So yes, children are at lower risk of severe disease, but there are still children that do get severe illness or get severe other outcomes associated with COVID-19, such as multi-system inflammatory syndrome. So I would say good safety data. They're important for protecting children from illness, and then also important for preventing further spread in community. So I'd encourage parents, if they haven't had their kids vaccinated yet, to please go ahead and do so.
Okay, that's perfect. Thanks.
Okay, great. Thanks, Dan. I have Lee up next. Lee, do you want to go ahead?
Good afternoon. Thank you, Dr. Bocking.
Hi there, Lee.
My question first off would be the outbreaks. A lot of outbreaks, obviously, with, I think you said 30, I believe. 15 among the most vulnerable in retirement and long-term care homes. But it seems the positive part about this is that the deaths are way down compared to what happened in earlier waves of COVID. So that must be encouraging for you to see. And I guess for that age group anyways, it seems like the vaccines are working.
You're right. It is encouraging when we compare this to the first wave of the pandemic, certainly seeing much lower rates of hospital admissions, ICU admissions, and deaths. We are still seeing some. So in the last 14 days, we have had 3 admissions to hospital and 2 deaths associated with residents of long-term care homes and retirement homes and COVID-19. So I wouldn't say the risk is 0, but certainly much better than previous waves.
Mm-hmm. And I'm assuming you're still doing a bit of contact tracing in terms of how they are getting these illnesses. And in the numbers I've seen, the staff numbers are well above the resident numbers. So it seems pretty obvious that the staff are getting sick in the community and then bringing COVID into the homes when they don't know they have it and aren't showing symptoms.
I think that really speaks to the importance of the ongoing screening that's taking place at long-term care homes and retirement homes, so that if staff do have COVID-19, because we know there's a lot of COVID-19 in the community, it's detected with that screening with the rapid antigen tests.
Thank you.
Okay, thanks, Lee. Next, I have Catherine Whitnell. Catherine, do you want to go ahead?
Certainly. I was listening in on the Trillium Lakelands District School Board meeting that was held last night, and the Director of Education said that school boards will now be responsible for whether a classroom is isolated or a school is closed because of COVID cases. Is that correct?
So the current guidance for schools is that classes or cohorts, whether it be in class or buses, will not be dismissed because of a COVID-19 exposure or case in that class. There's still, I think, a responsibility among school boards operationally to ensure that they have sufficient staff and support staff to be able to continue with classes. So there might be settings where a school is not able to continue a class for operational reasons, but not because of a case of COVID-19 in the class, is my understanding of the current, most recently released guidance.
So a bit of a follow-up. I had the distinct impression when he was speaking that the health unit isn't doing contact tracing for schools anymore.
That's correct. So as part of the updated guidance, there's no contact tracing. There's no requirement for schools to report COVID cases to public health. And in fact, public health likely would not be necessarily aware of a COVID-19 case in a school because they're not being tested via using PCR tests, which then other test symptoms are not being reported to public health.
So previously, and I apologize, so previously when there would be reports that the health unit had closed a school because there was an outbreak there, will the health unit still be doing that?
No, so there's no there is no guidance or direction to either, again, dismiss a class or close a school related to COVID-19. The outbreak definition for COVID-19 at schools, which used to be similar to long-term care homes, evidence of transmission of COVID-19 at the school. So health units will not be declaring outbreaks at schools as part of the updated guidance. The only time really that we will be, I think, revisiting that with school boards is if the absenteeism rate is becoming very high at a school. And so schools will be following that absenteeism rate, similar to what they do for other illnesses like influenza or GI outbreaks like Norwalk or that sort of thing.
Okay, thank you very much.
Great, thanks, Catherine. I've got Sue, and then I'm going to go back to Lee and see if Lee has an additional question or if its hand's still up. So Sue, do you want to go ahead?
Sure. Hi, Dr. Bocking. We've had some readers ask about masking requirements at local establishments, and I think it's kind of been a while since we've spoken about that. So I just wanted to check in. They say they've noticed shoppers allowed in without masks. They feel that there are more shoppers in now without masks. Can you just go over the current guidelines regarding the mask mandate and enforcement of that?
Yeah, certainly, Sue. And I'm a bit surprised to hear that because there has been no change to guidance related to indoor masking. So there are, under the current provincial regulations of the Reopening Ontario Act, there is required indoor masking in public places. And I would say that this is an even more important measure with how easily Omicron spreads, that we continue indoor masking in public places, especially if we're not able to maintain distancing. So I hope that you'll be able to share that information out. We know that bylaw officers and our public health inspectors will continue to follow up with businesses or premises about that masking regulation, we'll continue to do that.
Great, thank you. And another question, can you clarify, only those in high-risk settings are currently have access to PCR testing, and only outbreaks in high-risk settings are being reported. Can you just clarify what is considered a high-risk setting? I think we recognize some of them, but maybe not all.
Certainly, and I don't have it open right in front of me, so I hope I don't miss, if I miss any, we can also email it to you to confirm afterwards. But highest risk settings right now include hospitals, long-term care homes, retirement homes, other congregate settings, so group homes, for example. hospices, really, that's, I know there's some other healthcare settings that I'm not remembering off the top of my head, but really they're focused on healthcare settings or other settings that have individuals living in close proximity. Corrections, sorry, that would also is another congregate setting that would be considered a highest risk setting.
Okay, and so then in terms of the PCR testing, the folks who have access to that would be people who work in those places? Yes.
Yeah, that's correct. So people that work or live are residents of those settings.
Okay, excellent. Thank you.
There's also
I'll put my hand back up, Chandra. Sorry, go ahead, Dr. Bocking.
I was just going to say, add to that, Sue, that also individuals with certain medical conditions also have access to PCR testing, because that early diagnosis is important for how they might access treatment relevant to kind of their immune compromising condition.
Okay, and do you mind just noting some of those conditions?
Off the
top of your head, sorry.
Yeah, so I'm thinking about those people on certain medications that suppress their immune system. So if they're on medications, if they're a transplant recipient, have other autoimmune diseases, if people are undergoing cancer treatment. So there's a list of those, and we can send you either the link to the provincial website or the actual wording of it.
I think there's actually a link on our website. I could shoot that over to Sue as well.
Awesome, thank you.
Okay, perfect. Great, thanks. So Sue, if you want to take your hand down and go to the back of the line with more questions, I think I have Jessica next. Jessica, do you want to go ahead?
I do, thanks, Chandra. And I have a lot of questions, but I'm going to stick on the PCR testing to start. I think you'll notice, Dr. Bocking, we're asking a lot of questions because there seems to be a lot of confusion around the PCR testing. I know of teachers that have been getting tested here, but that doesn't, they said they were a teacher and they got tested. How, like, again, confusion. So are teachers on that list or not?
So currently teachers are not on that list. I know that the province is continuing to reevaluate who additional groups to be added to the list, because as they look at actual capacity for that, we can send you the updated list for who's currently eligible for PCR testing.
That would be helpful, thanks. Okay, so I'm going to move on to the deaths. You've had 5 deaths in the last 14 days. First of all, is there any more information you can provide? You said they're over 70. Were they in congregate living settings? Were they double vaxxed? And how many deaths does that bring your region to?
Oh, these are all good questions, Jessica, and I don't have all of the details for you right in front of me. We can get them for you. I've just pulled up a sheet here. So to date in our region, this is January 12th, cumulative deaths throughout the pandemic, we've had 68 deaths in total. We have had, among the 5 deaths in the last 2 weeks, all above age 70. I understand that 2 of them were associated with either a long-term care home or retirement home, but I will confirm that 100% and get back to you.
Thanks, Dr. Bocking. Okay, I'll move to the back of the line for my other questions. Thank you.
Okay, great. Thanks, Jessica. Next, I have Dan. Dan, do you want to go ahead?
Yes, thanks, Jen. Just first off, just to follow up on Sue's first question, I guess, if people have concerns about some loosening of masking rules or things like safety at businesses, I guess, would they contact the health unit or go through bylaw, or just who would we send them to, I guess?
Yeah, really, I think really either one. We work with all of our enforcement partners that include police, bylaw officers, and with those partners really determine who will follow up which setting. So for example, the health unit will often follow up those settings that we already inspect and so already have relationships with. So for example, restaurants are one example. But there might be other settings that historically the health unit has not had relationships with. We don't inspect as part of other public health provisions, and so bylaw might follow up on that. If it were to come to the health unit and it would be something that bylaw follows up with, then we would refer that over to them. So certainly if people have concerns, they can contact the health unit.
Okay, perfect. Yeah, and with some high schools returning to semester systems next month, I guess. From a public health standpoint, just what are your thoughts on semester versus quadmester system safety-wise?
Yeah, so I mean, it's tricky because one of our tools that we have used throughout COVID-19 and helping prevent the spread is cohorting and limiting the number of potential contacts that somebody might have. Obviously, in a high school setting, that approach is being weighed against the potential harms to education and the learning experience of high school students as they're going through this. And I think the adaptations to high school learning have worked, but have also been challenging for students. And so I think they're trying to strike that right balance. I think I'm hopeful that some of this wave will really have settled really before we're looking at increasing contacts at all. And certainly the other provisions in place, like masking, active screening, being sure people are not attending school if they have any symptoms, that all of those are being implemented at the same time.
Okay, great, thanks.
Great, thanks, Dan. So I have Sue back up again and then Jessica. Sue, do you want to go ahead?
Sure, sorry. Dr. Bucking, regarding the vaccine, you mentioned a few times that we know that 2 doses of vaccine is not as effective against the Omicron variant as it was the Delta variant. So we're asking people to get a 3rd shot, their booster shot. However, kids between the ages of 5 and 11 are only now getting, or will be soon eligible if they haven't already, for their 2nd shot. So can you speak to that a little bit? And I know you're trying to keep your answers short, and so that's maybe a big question, but is there a difference between 3 doses in an adult compared to 2 doses in a child? Is it about the time between the doses? What is working there in terms of efficacy of the vaccine?
Mm-hmm. Yeah, so good question, Sue. And I don't know all of the answers behind that. I mean, for adults, there was certain part of the concern was certainly waning immunity over time. So many people having received their 2nd dose of vaccine more than 6 months ago and seeing that some waning of immunity over time. Some of it is just in relation to the Omicron variant being different and vaccines not working quite as well against that variant. And I don't think we'd know 100% kind of the contribution of each of the different reasons why 2 doses was not working as well. We do know that older age groups are at higher risk of more severe illness, and younger kids certainly at lower risk. And I think that is reassuring when we're talking about emphasis and need for booster dose. There is still some effect of 1 dose and certainly 2 doses of vaccine. It's just not quite the same as what it was before against the Delta variant.
Thanks for that. And another question is just about, obviously there's some uneasiness in the community, in part because of, we've lived so long with this and we've learned about what has been important, in particular to public health over the past few years. So things like contact tracing, accessibility of testing, the importance of declaring outbreaks. And now those things that we become used to are no longer available, and so people do sort of feel like, we don't have numbers anymore. I know obviously we can follow hospitalizations, but can you speak a little bit to that? How are you feeling as a proponent of public health now that some of these things that we feel have been keeping us safe or have been allowing us to track and understand what's happening in our community are no longer available?
Mm-hmm. It's a big shift, and I think it makes sense that people are struggling with kind of reconciling this new direction with the messages we have reiterated and emphasized over the last 2 years, and so it's going to take a bit of time. I think that what is different now is Omicron, and Omicron is a variant that is very different from the previous variants, and it has forced us to look at this differently. We can't look at it the same way because we don't have the capacity to respond the same way, so we have to look at it differently. And I think that that's certainly helped us in public health really understand why we need to shift. And looking at what the goal is. So for previous waves, we still talked a lot about containment, that we can really stop transmission. And Omicron is so infectious that that's not part of the discussion anymore, or it can't really be, because we can't contain it. What we can do is we can mitigate it. We can blunt its impact on our healthcare system. And that meaning that we won't have as many people admitted to hospital or ICU. Hopefully we won't have to cancel surgeries, elective surgeries for a long period of time. And so when we move from containment to really mitigation, that's when we're looking at what measures we can do and can implement them. But I think it makes absolute sense that people are having a hard time shifting how we think about it. My hope is that this is kind of a next step before we get to hopefully an endemic state where, every time COVID-19 happens, we're not having to implement a huge number of restrictive measures to keep it under control. It will certainly continue to be here and will pop up here and there, but hopefully we'll be able to manage it in ways that are much less disruptive to education, the economy, all of these other things. So I think in that sense, I'm hopeful that this is moving us in a direction that in the long term is going to be much more sustainable to move forward.
Thanks for that. I'm out of questions, but anybody else can feel free to follow up.
Okay, thanks, Sue. Jessica, you're up next.
Thank you. Back to the walkouts on Moderna. This is something that we saw in the beginning of the pandemic, and then I guess we had ample supply of both, so we didn't see it for a while. When did this kind of start again, and how many cancellations or walkouts are you seeing now on average?
Mm-hmm. Yeah, it is interesting because it is kind of a repeat or a deja vu. So we started to, and this is certainly across the province, started to restrict access to adult Pfizer doses, I want to say about 2 weeks ago. And I think as people became more aware, we started to see some cancellations. I think on average, we're looking at about 10%, just less than 10% of appointments on any given day that people don't end up keeping that appointment because they don't wish to receive Moderna.
Okay, and I was wondering about expiration dates, because I'm thinking, I don't know how long they last. I know there's a certain time from when they're punctured. So maybe if you can reiterate that, but then also how long they last overall. Because if it's a shorter time, then we'd have to start giving Pfizer out because you're saying youth aren't coming in as much. So from the date it's punctured, how long does it last? And then how long overall is an expiration date if it's unopened?
So good question, and I don't have that answer right in front of me, Jessica, because it also differs between Moderna and Pfizer and the formulation. Like the pediatric formulation of Pfizer is different from the adult formulation. So if we can, I'd like to send you that in an email to make sure that we get you accurate information.
Perfect. Yeah, that's great. Thank you so much. And I think that that's it for me. Thank you for all your time, Dr. Bocking.
Okay, great. I don't have any other hands up after Jessica. Lots of questions today, lots of good questions. I'm just checking to see if anybody wants to throw a last hand up because we are almost, we're just before 3, I guess, just before 3 now. So going once, going twice. Okay, I don't see any additional hands. So again, thank you to everybody for joining us today. Lots of good discussion, lots of interesting questions. And we always appreciate you getting the information out and sharing this with your readers or your viewers or your listeners, just to make sure that everybody has the most up-to-date and current information. So, and a big thank you to Dr. Bocking for for providing the update and answering everything. So I think with that, we can probably wrap it up for today. And we will follow up on the email for Jessica on the vaccine. Thank you. Blah, blah, blah. And I sent Sue something, and I don't know if I owe anybody anything else. Was that it?
I wouldn't mind the PCR, the link that you sent to Sue as well.
Okay,
Thanks.
I can send that to you as well. Okay, perfect. Good. So on that note, we will say goodbye and we will see everybody next week. Okay, thanks
Thank
everyone.
you very much.
Very much.
Bye.
Take care, everyone.